Hello, my name is Mark Freestone. I'm a reader in mental health at the Centre for Psychiatry in the Wolfson Institute for Preventive Medicine at Queen Mary, University of London. And I'm here today to give you a sample of the new master's course in mental health economics. And I'm going to focus the talk today on the implications of a diagnosis of personality disorder for public health. So personality disorder is a mental disorder that represents a chronic mental health problem. People who have a diagnosis of personality disorder, or PD, have a chronic dysfunction of either cognition, that's their thought patterns, their affect, that's their ability to regulate their emotions, or their relationships. And that problem has to be persistent, pervasive, and pathological. So that means it's been present since they were young adults or teenagers, or perhaps even before, that it's pervasive, it affects every aspect of their lives, whether that's their jobs, their personal relationships, intimate relationships, family relationships, or their education, and it's pathological. That means it causes them significant distress or dysfunction, or sometimes distress or dysfunction to those around them. We also know that there's a 10% suicide mortality rate among people with personality disorder, and we have some ideas that some diagnoses of personality disorder are linked to trauma and complex trauma in people's past. A major problem with personality disorder treatment, I think everywhere in the world, is that the services can feel a little bit like an ambulance at the bottom of a cliff. By the time that people come into services for treatment, it's usually too late. The damage has been done. Somebody has suffered a significant problem in their relationships. They may have had contact with the police. They may have committed a serious act of self-harm or even attempted to take their own life. So my talk today is going to think about, well, how important is it to focus on preventing this disorder or preventing outcomes associated with disorder rather than treating it? So what do we know about the prevalence of personality disorder? That's the number of people who'd be diagnosed with personality disorders in the UK population at any one time. Well, we know from a study by Coyd and colleagues out of Queen Mary, University of London in 2006, that the overall weighted prevalence, that's accounting for any variation in the sample, of personality disorder diagnosis is about 4.4% in the UK population. And this was based on a nationally representative sample of about 8,000 people, so we're pretty confident in that estimate. Now, personality disorder diagnoses are grouped into three clusters. We have cluster A, which is what we call the odd or eccentric disorders, such as paranoid personality disorder. Cluster B, the dramatic or erratic personality disorders, such as antisocial or borderline. And cluster C, which generally refers to the anxious or fearful personality disorders, such as avoidant and dependent personality disorder. So while the prevalence of something like obsessive compulsive personality disorder is quite high, at around 2% of the UK population, some personality disorders have very, very low prevalence in the UK population. For example, schizotypal personality disorder, you can see in my slide here, is only prevalent in about 0.06% of the UK population. And in this particular study, we found nobody with a diagnosis of histrionic personality disorder whatsoever. We also know this figure is probably about in the region of what we'd expect in other countries. So a study by the World Health Organization in 2009 found that around 6.1% of people had a diagnosis of personality disorder. What we also know about personality disorder is that it tends to be far more present in institutional and specific populations in the United Kingdom. So in inpatient mental health settings, the prevalence of personality disorder rises to around 33 to 67%. So around a third to two-thirds of people who have who've sought mental health service treatment for anxiety, depression, or psychotic disorders such as schizophrenia will also have a personality disorder. Within prison settings, that estimate rises to around 60 to 80%. So the vast majority of people in prisons will have a diagnosis of personality disorder. And among the homeless, some estimates have put the prevalence of personality disorder as high as 92%. It's important to know this because we also know that the outcomes for some personality disorders are extremely negative. For example, people with a diagnosis of a cluster B personality disorder, such as antisocial or borderline, are 10.5 times more likely than someone in the general population to have a criminal conviction. They're 18 times more likely to have been in institutional care before the age of 16, and they are 7.5 times more likely than the general population to have spent some time in prison. We also know that the suicide rate among people diagnosed with borderline personality disorders is around 400 times the national average. And this leads to the often quoted statistic by Jill Paris that around 10% of people with a personality disorder will commit suicide, which has huge implications for public health. And I'm going to work you through why this is such a problem over the next couple of slides. The reason I did this analysis was actually a question from a colleague who's a very respected cancer epidemiologist, and he said to me, well, what does that mean? If 10% of people with personality disorder will commit suicide, what does that mean for public health? What's the epidemiological and economic implications of that? So my first question was, how many people in the UK with a diagnosis of personality disorder will commit suicide per year? We know that the population of the UK is around 65 million people. And we also know that around 6,000 people per year commit suicide, according to the Office of National Statistics in 2016. We know that the prevalence of personality disorder in the UK is around 4.4%, which maps to about 2.68 or 2.7 million people. The overall suicide mortality rate in personality disorder diagnosed people is around 10%, so 268,000 people. The average life expectancy in the UK is around 82 years. There's some variation between men and women, and again that's a figure from the Office of National Statistics in 2015. So the suicide rate per year of people with a diagnosis of personality disorder is around 3,000 people, or 50% of the total burden of people who commit suicide will have a diagnosis of personality disorder. This also affects the life expectancy of people with this diagnosis significantly. Marcella Fock and colleagues conducted a study in South London where they showed that the average life expectancy of women in the general population is around 82 years, but for women with any diagnosis of personality disorder, that falls to around 63 years, so almost a 20-year difference in life expectancy. For men, the difference is almost the same. Men have a slightly lower life expectancy than women for reasons that I won't go into here, but again the difference between men with a personality disorder to those without personality disorder is around a reduction of 17.7 years, so a very, very significantly shorter life expectancy. Now, not only does a diagnosis of personality disorder have huge implications for somebody's life expectancy, it also has very large implications for the economics of health care delivery. We know that the mean annual cost of managing somebody with a diagnosis of personality disorder, and this is based on a figure from 2006 that I've adjusted for inflation to 2017 levels, is around £13,000 per year, of which around 7,000 or 8,000 are medical costs and 3,000 to 5,000 are indirect costs, such as police time, potentially jail time, and other social care support costs. If we think of the prevalence of personality disorder in the UK as being about 4.4% or 2.68 million, that means that the overall cost burden simply of managing people without any specialist interventions whatsoever is around £35 billion to the UK population every year. We also know that around a fifth of people who attend GP appointments in any given year would meet the criteria for diagnosis of personality disorder, and that these people are more likely to be frequent reattenders for GP care and be on average around 3 times more expensive than the average patient who doesn't have a diagnosis of personality disorder. It also has implications for the mental health system as well. So the number of mental health bed days used by patients with personality disorder in 2006 was around 42,000. If the cost of a bed day in acute adult services in 2006 was £259, then that means that the inflation adjusted annual cost of hospitalisation for somebody with a personality disorder is a further £14 million. So this is a huge economic and public health burden on general services for mental disorder by people with a personality disorder specifically. But what I am going to say is that we can focus on preventing the negative outcomes that people with personality disorder tend to experience. And in writing this, I was inspired by a quote by Len Bowers, Professor of Mental Health at City University, who said that people with a diagnosis of personality disorder are not bad all the time or bad to the core. Rather, their dysfunction becomes apparent regularly and periodically. And usually we know this is when they're placed under stress. So my proposal is that we take 4 different strands of intervening to prevent negative outcomes for people with personality disorder. We need better research evidence about the epidemiology of personality disorder and who it is who has a diagnosis of personality disorder who goes on to access services, to try and work out what might be preventable within this large and quite heterogeneous group of people. We also need better awareness of the implications of personality disorder, which involves both psychiatrists and public health experts, and a degree of training for all people delivering mental health services so that they're aware of the implications of personality disorder and how to identify it and try to prevent negative outcomes of people who may have that diagnosis. And this involves promoting confidence and resilience in people who work with those with a diagnosis of personality disorder as well. Remember, if 20% of GP attendees have this diagnosis, that means that everyone in the entire NHS should really have some level of awareness of the implications of personality disorder. And finally, because such a large burden is placed on the primary care system by people with this diagnosis, we need to have much better non-specialised treatments and interventions, a degree of psychoeducation, or simply adapting existing therapies such as the IAPT or cognitive behavioural therapy services for people with a personality disorder is likely to cost very little, relatively speaking, but have potentially a huge impact on getting people back to work and stopping them from using inadequate GP services. So my 4 take-home messages. Firstly, the public health and economic burden of personality disorder is far greater than many people realise. Secondly, people with a personality disorder are often invisible to services because they have many different diagnoses, including across axes of the DSM, meaning that they may present with a diagnosis of depression. And actually that comorbidity tends to be the rule rather than the exception when it comes to personality disorder. Thirdly, we lack good research evidence and particularly good epidemiological studies that explore the cost-benefit analysis of low-level primary care and general population interventions for personality disorder. And finally, there's a role for all mental health professionals, anyone involved in treatment or treatment delivery in the NHS or even private care facilities, in raising awareness about the issue of personality disorder and how we can all work in a more sympathetic and effective way in managing people with a personality disorder to make less heavy use of our services, or in other words, to be more effective in the way that we manage them. Thank you very much for listening. I've put a list of some of the citations that I've used in the final slide, and I hope you found this lecture enjoyable.